So, hello, everybody. It's Carol Petersen, and I have a guest today. I'm so excited. This is Dr. Bryan Treacy, and I asked Perplexity for a little bio I'd like to share with you. So, Dr. Bryan Treacy is a preventative medicine physician and health coach based in Boonville, Missouri, with over 37 years of clinical experience. He earned his medical degree from the University of Missouri Columbia School of Medicine in 1986 and completed his residency in obstetrics and gynecology at the University of Nebraska Medical Center. Dr. Treacy's expertise spans addiction medicine, women's health, integrative medicine, men's health, and regenerative medicine. He transferred from clinical practice to health coaching and consulting role, focusing on helping patients understand and manage health risks, hormone balance, and chronic disease prevention with natural and holistic strategies. He is also an adjunct, professor who has developed innovative clinical programs, including robotic gynecological surgery. Dr. Treacy emphasizes age management, hormone optimization, and patient education. How's that for Perplexity? Did they make any mistakes?
Perplexity did a pretty good job. I've Googled myself, but I've never AI'd myself.
So, yeah, very, very good. So I wanted to talk with Dr. Bryan about hysterectomies. And as a obstetrics and gynecologist, he's been in those surgeries. And I think this is a really big public health issue, really. We have about 600,000 hysterectomies performed every year in the US. That's a staggering amount of surgeries. It's second only to cesarean sections. And we probably overdo those too, and probably could be another
That's
talk
right.
another day. I
And
think we
circumcision.
and circumcision. Oh, yeah.
And then
Uh,
circumcision. Yeah.
yeah, another unnecessary surgery. So today I would like to get started on this topic. I was just reviewing with Dr. Treacy. Why do people end up seeking a hysterectomy? And even worse, doctors telling them that's their only solution. So, in my experience, bleeding and fibroids are big reasons. I suppose you could throw in endometrial cancer, and that might be a reason. And then ovaries, cysts on the ovaries. And one big category that I don't think is talked about much is the women who have been diagnosed with PMDD, premenstrual
Dysfunction.
dysphoric disorder.
Right.
And that's another whole story.
That's a
So,
whole podcast right there. PMDD.
yeah, maybe we'll save it for another time, coming soon.
Right.
So, when you were in practice, you indeed did some of those surgeries. And how many patients, as you look back over your life, how many patients could you have saved from that if you knew then what you know now after all your years of experience?
Well, my years of experience morphed. So I kind of was trained by two very good GYN oncology surgeons at Nebraska, one of whom is still practicing, who's retired. So it was surgery, 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 surgery. That's what we did. And of
Mhm.
course, they leaned toward every patient that had anything going on. We got to rule out cancer. Let's take all the parts out and look at them under a microscope. So I got very good at avoiding abdominal approaches. And so most of the hysterectomies that I did were done before the robot and the laparoscopes by vaginal hysterectomy. I was a member of a society called the Society of Pelvic and Reconstructive Vaginal Surgeons. So I was trained as a vaginal surgeon by two private practice doctors, surgeons at Methodist Hospital in Omaha. So I was trained very traditionally at the university, and we had outreach areas during our residency. We could go work with other surgeons in private practice. So I sort of had kind of a cool training that way. Let me turn that off. Sorry. So I think if I go back in retrospect, I wouldn't have saved a whole lot of my hysterectomy patients because they had it in their mind that's what they wanted to do.
Yeah, and well,
And I,
they certainly encourage to think that way.
yeah, and I think
Uh,
that had to do. Yeah, I think a lot of that had to do with, well, you get to a certain age, you're done having
you
kids.
don't need those parts
You
anymore.
don't need that part anymore. Let's just take it out. There was a guy that I knew in Norman, Oklahoma. No, I'm wrong. He was in Lincoln, Nebraska. This guy, we're going back into the 90s when I was early in my career. This guy would tell his patients on their 35th birthday year annual exam, well, you're 35, it's time for your hysterectomy. And he did a hysterectomy at 7 or 8 o'clock in the morning every Monday through Saturday through his entire career.
Oh my God.
So he went into practice probably in the 60s.
Oh my
And in
gosh.
the 90s, he was up in his 60s, and just, I mean, he did it his whole career. And women would say, yes, doctor.
Yeah,
They would
and
say
and
yes.
know nothing more about it. Well, thank
Yeah.
goodness for Google. So let's
And they,
start.
he would tell them, you're too old to have babies. You're 35, you're too old to have babies.
Oh,
It's
and they
time to
still
take your
could another decade. Yeah, easily. Well, I don't know if that easily. So one of the things that I see so much of is bleeding issues that start at even early perimenopause or even back at PMS really, but heavy bleeding.
Yeah.
And now that we know so much about hormone balance, there's other opportunities to fix this. And I remember one young girl, actually, she was in her 20s, and she was bleeding so much. Every month she went to the hospital to ER for a blood transfusion. That
Mhm.
that heavy. And you know what those doctors told her to do for the next month? They told her to double, triple birth control pills, which are highly estrogenic. So they were kind of setting her up for the next month when those birth control pills would be building up another heavy layer for her. And that's what she was doing month after month. And she was desperate to save her organs. And when I was working at the compounding pharmacy, we gave her eventually 1,700 milligrams of progesterone every day, and it stopped her bleeding. And she had a desperate need for progesterone. You say, why so high? Because conventional medicine seems to think that you should never go any higher than 200 milligrams of progesterone. But where you really need that support is in the follicular phase. That's when you're doing all that building up. And I think you have to play around with this a little bit, but you can use progesterone, but you can get it high enough so you don't ovulate. And maybe you want to avoid that. There's kind of a layer there, maybe 100, 200 milligrams, maybe a little more, and you'll still ovulate, but you could block ovulation. And maybe you don't want to do that.
Well, high dose progesterone is, and that's one way of doing it. The only time I used medroxyprogesterone acetate, which is a progestin, which is different than
Hmm.
progesterone. I hated that drug. It had horrible side effects, like weird headaches and all kinds of stuff. But I would use it in that situation at a high dose because and so does natural progesterone. You create a medical dilation and curettage.
Yeah.
So
Ver-
you're eventually stripping out the uterus and all the estrogenic buildup, so there's nothing left to bleed. But, and I saw this all the time, family docs and other GYN docs, they put patients on a birth control pill or twice a day or 3 times a day, or they'd put them on medroxyprogesterone acetate for 10 days and then take it off. Well, menstrual bleeding starts when you withdraw progesterone. When the progesterone level drops, you start bleeding, right?
well, no, I'll argue that point later.
But
But but
you would,
medroxyprogesterone acetate, yes, for sure.
yeah, for sure. So you would do 10 days, they'd stop it, then they'd start bleeding again. They go, oh, well, it's not going to, medical therapy is not going to work. We need to take your uterus out. That's the narrative.
Yeah. Do you remember there was a time I remember working in a regular pharmacy that a woman who suspected she might be pregnant actually was given medroxyprogesterone acetate for 10 days. Stop. If she bled, she wasn't pregnant. If she didn't bleed, she was pregnant. And they had to stop this little off-label kind of thing because they were producing birth defects with
Yes,
this drug.
I've never heard that story.
You never heard that?
How far back does that go?
It goes back a ways, maybe 40 years, 50 years.
Well,
Interesting.
I've never heard that. Yeah,
Yeah,
that's
interesting.
interesting.
So there are ways also. One of the things I learned over the years when I first started, progesterone seemed to be our only tool and some generous amounts for a lot of things. But now we know a lot more about why is the estrogen so abundant. We call it John Lee called it estrogen dominance, where there's so many reasons that estrogen can be the problem. It's more prolific than your amount of progesterone can handle. Even when you're younger, as this young woman was, she had trouble making enough progesterone to handle that estrogen stimulus. So what would you do with this woman if you how where would you look for where all that estrogen is coming from?
What's the age again?
Oh, early perimenopause. And here's where women are allowed to have heavy bleeds.
Yeah.
Every month they have a really heavy bleed and they even get anemic. And their doctors tell them, you can put up with it and eventually you're going to want a hysterectomy. And that's probably when you saw them at the surgery because they couldn't handle the heavy bleeding anymore.
Well, sure. Yeah, they were. And the bleeding comes from progesterone deficiency, and that's
Yes,
just the way it is. That is the reason that women after 35 are not as fertile. So the main fertility age for women is 24 and 25. At 35, if you graph it out, there's like a drop off of the cliff. And then at 40, there's a big drop off the cliff. And it is ovarian dysfunction and it is mismatched estrogen and progesterone production. Specifically, the dysfunction is producing enough progesterone.
right. That's
That's
how
how.
you look at it.
Yeah, so I would use a lot. I mean, before I'm old enough to remember there was no such thing as micronized progesterone that could be taken by mouth because the enzymes in the stomach would break down the progesterone. So we're going back to when I needed progesterone support in early pregnancy for my infertility patients or people that had luteal phase defects or recurrent miscarriage.
Mhm.
I had a guy named Mike. He owned Mike's Pharmacy in Omaha. And I called him and I said, okay, so how can I get progesterone in these women without giving them shots? Because I could
Yeah,
give a shot. And
very
so he,
painful, these things,
yeah,
and women did do that.
yeah, and we did it a lot. So and then there was suppositories and there was rectal stuff and vaginal stuff. I'm like, they don't want to do all that. So he came up with a brilliant idea. He injected progesterone into gummy bears. So you could have gummy bears. So all my patients would take the progesterone by chewing on their gummy bears, and he had stuck it in there.
Oh, great idea. I love it.
So yeah, so the micronized progesterone prometrium came out, and that rectified that problem. But I still had women that they would rather take a shot. So we give them a shot once a week. And then we found that if you gave 17 hydroxyprogesterone caproate, you could reduce preterm birth. So I would give shots of that.
Yeah, do you know that was in favor and even got an FDA approval, but now it's fallen out of favor. Actually,
Yeah.
progesterone should work just as well.
Should.
So why bother? And I think the treatment cost was hugely expensive once it got to be an approved drug. But you're
Uh,
you're absolutely right. We
that was
did some of that compounding too back then.
Yeah, that was from a paper in the Society of Perinatologists for preterm birth, and you could get it. I used to get it from a compounding pharmacy in Fort Smith, Arkansas. I would get 50 doses for $80. And I would just keep it in the office and give the patients a shot once a week. And then it got FDA approved. They squashed the compounding, and then it
Yeah.
became 36. They went up to $36,000 for a treatment that
Oh,
used to.
wow. Yeah,
I would
pennies.
tell patients, I tell patients, give me $10 a week for week 16 through 37. That's how we did it. And then that
Okay.
went.
Yeah, so for
progesterone's a big deal, is what I'm saying.
Yeah, I agree. Totally a big deal. It does so many things. So I want to back up. Also, when there's heavy bleeding, there's often fibroids involved.
Yeah.
So women develop fibroids. Dr. Jerry Lynn Pryor said the fibroids don't bleed. It's the endometrium that bleeds. What's your opinion on that? Would you agree?
Yeah, I agree because fibroids have no blood supply.
There you go.
And I know that because I just saved a uterus this year for a woman that didn't want a hysterectomy and she had fibroids. And I said, you just need to find a surgeon that can take the fibroid out and sew the uterus defect back up. And when you do that, surgically, you have to cut into the fibroid and you bivalve it, and there is no bleeding at all. You can cut the biggest fibroid. I mean, I've cut fibroids this big, this big, this big. They don't bleed at all.
Oh, that's good to know because so many people are told, or women are told, their fibroids are bleeding. I talk to them and they're convinced that that is the case. And I had never thought about it until Jerry Lynn Pryor brought it up, and I go, well, that makes sense. You don't really need to have a blood supply. But there is this question with progesterone and fibroids. And do you remember Alan Warshawski wrote a book on treating fibroids? And he used progesterone, he used nutritional stuff. But he asked me one time, he said, Carol, fibroids seem to grow sometimes when you use progesterone. Did you ever see this in your practice? No,
No,
no.
the ones that grew were they're estrogen dependent. So fibroids eat estrogen for lunch.
Yes.
That's what makes them grow. And
Uh-huh.
what's the most common treatment for fibroids? Birth control pills, which has a much higher strength estrogen in it than just
Yeah, just plain
biological.
estradiol, for
Just plain
instance. Yeah.
estradiol. So you put them on ethanol estradiol, it's 5 times the power. And then they say, here's the narrative again. Well, take this birth control pill. Well, the fibroids are getting bigger, you're bleeding worse. Time for a hysterectomy.
Yeah, yeah. So
That's
I don't want to lose, just I want to expand just a little bit on the surgery you mentioned. That's called a myomectomy. Am I
yes,
correct?
that's
Yes.
right.
And you just remove that fibroid and that surgery is available. So I just gave everybody how many hysterectomies were performed every year. So I went back and I asked how many myomectomies were performed in the US each year. Would you like to guess?
500.
It was up to 30,000 last year. Still,
Okay,
in
well, that's good. So
comparison,
because when I started doing them, no, everybody thought I was a moron. And that was, I mean, it was a described procedure, but no, everybody thought it was so dangerous, you're going to wind up taking the uterus out anyway. And
so
guess how many hysterectomies I had to do because the myomectomy was bleeding too much.
zero. Wow,
I could always do a myomectomy and then repair the defect in the uterus and they're done.
they're done. Yeah, I simply think it's not, they let women bleed and go right onto the hysterectomy.
Yeah. And you don't even sometimes the small ones, you can use a bipolar cautery and just burn through them. You just burn them up.
Now,
So I've done
what about ablation, uterine ablation?
uterine ablation for the lining of the uterus. Yeah. I mean, when that came out, it used to be what was called a roller ball, a hysteroscopic roller ball. And that took some dexterity. And then they came out with what I thought was brilliant. I first was introduced to hydrothermal ablation, which used water at the American College of OBGYN meeting in Boston in 1996. And I got one of those machines for my OR, and we just started doing endometrial water ablations. The nice thing about it is you're seeing what's going on,
Mm-hmm.
and you're heating water up in the uterus to about 200 degrees. So it's just below boiling, and it destroys the stratum basalis of the endometrial lining.
So that lining never proliferates again, or does some of it come back?
Well, some of it could. I mean, you would have to destroy every basal cell of the endometrium, of the endometrial epithelial tissue. So sometimes they would still spot a little bit and bleed. But as far as failure, it all grows back and they start bleeding again.
No, no.
Never saw that.
So what are some of the long-term problems with having had a hysterectomy? Just
I've got so I've got so many little things that I used to say to people that probably if I said today I'd get in trouble. Women would come in to they'd come in and say, well, I'm tired of having periods. They hurt and they're a pain and I have to buy, you know, products and stuff. Just take my uterus out. And my next question was, what are you going to do when your vagina falls out 20 years from now?
yeah, exactly.
That's the biggie. And they go, what happened? And I said, well, go to a nursing home and start looking at the women that are in the nursing home who have total vaginal prolapse and they've had a hysterectomy 20, 30, 40 years previously. So there's to do hysterectomy and avoid that, but most surgeons aren't taught that to resuspend the vaginal cuff once you've taken the uterus out. You have to
Oh,
you have to put the vaginal cuff on the ligaments that you just cut, or
boy, it's gonna fall off.
it's going to fall away.
Oh my gosh. And then I've heard like shortened vaginas is possible, and that's not very nice either if you have any sort of sexual relationship. And then what about the bladder?
Well, you have to address the bladder maybe separately. So if you're doing a hysterectomy for prolapse, I guarantee you're going to have some form or some issue with rectocele, cystocele, and those are hernias. They're fascial hernias. So taking a uterus out, the bladder fascia is attached to this pericervical tissue, and so is the fascia between the vagina and the rectum. So if you take the uterus out, you get a big hole in the fascia, you've created a hernia. And if there's some partial fascial dehiscence, I'm sorry to use big fat words, but
That's that's
breakdown
okay.
breakdown of fascia that is involved maybe from vaginal birth, then you just made the problem worse. And then down the road, you're gonna start having to deal with the cystocele and the rectocele. If not
Okay.
all at the same
So
time.
so how about a definition real quick of fascial and cystocele and rectocele?
So cystocele is a bladder drop, is the typical terminology most women would know. And a rectocele is a bulging of the front wall of the rectum coming from the back wall of vagina. So it's not like you look in the vagina and see a rectum, you see a bulge. And if you went through the skin of the vagina, through that bulge, you'd be in the rectum. And same thing with the bladder. So if you went through the bulge, and most women that bulge their bladder know that. They'll see, like postpartum, they'll have a vaginal birth and they will sit on the toilet to go to the bathroom and they look down, they see their bladder sticking out. That's a cystocele.
Oh my goodness. So women in general, they're not warned about all these long-term effects. I just recently saw a study that said women who had hysterectomies and oophorectomies, that's when the ovaries would also be removed, that their lifespan is actually 10 years shorter. Had
That is
you,
true.
that's true. Who gets told that? It's
No,
just
but
horrible.
I'll tell you the person that made me think about that the most and made me realize saving the ovaries is important was a guy named John Rock. And he's a fairly well-known gynecologist. I don't even know if he's still alive because I was in my 20s probably, and he was in his 50s. And he said, just because they're not ovulating doesn't mean that they're not doing something. They're not dead. So even women we were always told if a woman is perimenopausal or menopausal and you're doing a hysterectomy, you should take the ovaries out to save their chance of having ovarian cancer later. That's how I was trained.
Yeah.
And
Hold
I
that
go,
thought. I want to bring up something about that. But okay.
so as the hormone doctor that I became after dealing with infertility women that were in their 40s, I thought, well, if you take the ovaries out of a 43-year-old, you have accelerated her aging in 20 minutes by 10 years.
Yeah.
So you take a 43-year-old, take her ovaries out, and she is immediately 52, 53, hormonally.
Yep. Shocking.
I know, and nobody ever tells them about that. If I take your ovaries out, you're going to lose half your testosterone immediately.
Yes.
Even if you're 55, you're going to lose half your testosterone.
Just like that. And they certainly feel that. Okay.
Yes.
I want to do one more point and we're going to finish up and start another one. I want to
Yeah.
keep people's attention. But After that hysterectomy, their doctors are giving them estrogen only, right? Hysterectomy,
Yeah,
oophorectomy. And of course, we don't need any progesterone because you don't have a uterus anymore. Forget the rest of the body.
right,
We don't have half of our testosterone anymore. I
right,
understand the ovaries make some DHEA too. Lord knows all the things that those ovaries might be doing. We haven't even discovered yet. It's like we don't need to go to outer space. We have our inner spaces we don't even understand yet. What's
right.
been your experience with that?
I put every woman that I see who's not on estrogen and has lost their ovaries on progesterone, every one of them. And I've been doing that for, gosh, 20 years probably, because it's that exquisite, and I want to say balance, and I'll tell you why in a minute. But there is a ratio or a balance between progesterone and estrogen, 17 beta estradiol specifically. And if you eliminate that, then they are by definition estrogen dominant forever,
Right.
especially if they're prior to menopause. And then if they're a little heavy and you take the ovaries out, they may not have hot flashes because they're making estrone in peripheral body fat. So, but you still have an imbalance between the physiologic measures or levels between progesterone and estradiol or estrone.
These women become great candidates for sleep aids, anti-anxiety drugs, the benzodiazepines, the
Yes,
antidepressant drugs, and the hypertension drugs, and now the GLP-1s and everything
yes.
because they're a good market after that hysterectomy for much more pharma intervention.
Absolutely. And there's absolutely no reason not to give a woman progesterone. There really are no side effects to progesterone. The micronized progesterone is actually progesterone. So progesterone has no side effects. I mean, the worst one I've heard is I get warmer and I sleep better. That's the only two side
Yeah,
effects I
it's
hear of
supporting
progesterone.
your thyroid. Okay, let's stop here, Dr. Bryan. Thank you for doing this with me, and we'll be back shortly.
Yeah, anytime.
Let's see. Hi, this is Carol Petersen, and I am with Dr. Bryan Treacy, who had been trained in obstetrics and gynecology, and he's done hysterectomies and surgeries just to get a little background on what happens with these surgeries. He's retired from his medical practice and he is now a health coach and he's just full of the wisdoms of the ages. I always said to people, if you looking for a good doctor, try an old one because you learn from people as you go. And you were just about to tell me a story. So let's go to your story.
Well, my story, I'm a big movie guy and a big TV guy because I think art imitates life. And I can't begin to tell you how many times I've learned something from reading a book or seeing a movie with script that puts words together in a way maybe that I can't because, I've got that ADHD scientific brain. So the story was on this other episode, you were asking about sexual changes or maybe sexual dysfunctions that occur after hysterectomy. So my story is this, and I want to say it was late 1980s, I think, when 30 something was on television. The actress was Patricia Wettig, and she, during the course of, I think, the fourth season, developed ovarian cancer.
Oh my.
And I was a resident. So now this is the storyline. It wasn't cancer. And her GYN doctor, her GYN oncologist was a woman, which back in the 80s for gynecologic cancer was pretty rare. Like all the GYN cancer surgeons I knew back then, except one, were men. So anyway, she has a hysterectomy and she's coming in for her, I don't know, 6 months check. And she's angry, the Patricia Wettig, the patient who had the hysterectomy. And this doctor's like taken aback. What are you so mad about? And she goes, you told me that having a hysterectomy would not change my life in any way, and you lied to me. And again, this is the 80s, and the line, the reason she was upset is because she could no longer have an orgasm because her cervix was gone. And she was a woman that cervical manipulation triggered orgasm for her. And so
Wow.
they had that as a storyline on network television
Vision.
in the 80s.
And
And
there
I
you
was
were.
around.
You were the surgeon.
Yeah. So I'm a senior resident. I was a chief resident at that time. And earlier in your residency, you just work 115 hours a week. When you're the chief resident, you get a little bit of time to do stuff. So I happened to be watching that story, and I thought a little light bulb went off, and I go, nobody ever talks about what's your sex life like after a hysterectomy. And it took a television network program to teach me that lesson.
Yeah. And
So when
that's
I
a,
did hysterectomies, my let's go over your surgery, risks and benefits of surgery. My pre-op consult for a hysterectomy took about 30 minutes because we talked about all that stuff. We talked about vaginal prolapse. We talked about procedentia. We talked about total urinary incontinence, fecal incontinence, change in sexual response, change in orgasm, change in all that. So it took a bit of time to do an informed consent before they signed a consent form to actually have surgery. And so I moved from doing hysterectomies, as that's what I was trained to do, to spending most of my career after about the first 5 years saying, yes, hysterectomy is an option, but here's 6 other options. Let's work through them all together and figure out what's going to be satisfactory for the rest of your life. Because once I hysterectomize you, I can't put it back in. I can't reverse it. Plus, I would tell people, you realize that surgery is assault with a deadly weapon, and you're giving me permission to assault you with a deadly weapon.
yep.
Right?
Did,
So
did
any
you
surgery,
change people? Did you change some minds with
I
your
did.
things and offered them some other solutions? With that's fabulous.
I sure did. And there was other women, they're just like, my insurance will pay best for hysterectomy. That's what I want to do. And I would even push it far enough to say, so you're willing to risk your life because your insurance company will pay better?
Yeah, I've heard
How
that.
many,
There's
yeah,
something really warped,
yeah.
very
And
warped
so
about our
they
society. What point does this happen when this becomes so unbearable that you would want to remove the ovaries?
well, of course, it would depend on what you think you're heading into. But okay, so the risk of ovarian cancer, I was trained by a GYN oncologist. So everything that's a cyst is cancer until proven otherwise. But there are some ultrasound criteria that kind of tell you maybe we ought to do a frozen section and surgery or just remove the ovary. Typically, the pain from an ovary is the stretching of the epithelial neural tissue. So the nerves hurt. So if you just drain the cyst, that's going to go away.
Oh,
The
wow.
question is, if you just drain a cyst, did you
Mhm.
miss something that is borderline cancer, et cetera? So that kind of is based on age. I mean, 22-year-old women with ovarian cysts don't have ovarian cancer.
Mhm.
Okay. Has it ever happened? Yes. But if you did a ovarian cystectomy on a woman in her 20s, which would be a fairly simple thing to do, either drain a cyst or you can do a cystectomy and remove the cyst. If your pathology came back and said this is a borderline tumor or this is actually cancer of the ovary, then you would have to go back in. So how often does that happen? Depends on age. So pretty rare under the age of 50.
Okay, so we have a disease called polycystic ovary disease,
Yes.
and that tends to occur in young women and maybe doesn't even get diagnosed until that young woman is trying to get pregnant. And she has erratic cycles or no cycles at all. And ultimately, she gets that diagnosis. Yet, if she should happen to get pregnant, the whole thing disappears, does it not?
Yeah, kind of like rheumatoid arthritis disappears. So
Uh,
pregnancy is therapeutic for PCOS, really. But the problem is their fertility rates are lower. And polycystic ovary syndrome, when I was training and until just recently, nobody could really explain why somebody had PCOS. So the basis of the diagnosis is the true diagnosis is called Stein-Leventhal syndrome back from the 1880s. And the classic PCOS patient is the bearded lady at the circus.
Yes.
I've seen enough of them. I can kind of go to the mall and pick out who
Oh,
I think
yeah,
is.
for sure. And this is
So,
where progesterone is so important.
yeah,
Progesterone is a 5 alpha reductase inhibitor in
uh-huh.
that it provides some competition to those androgens. So both testosterone and progesterone are substrates for 5 alpha reductase. When it works on testosterone, it goes to dihydrotestosterone, the more active testosterone derivative. And when it's working on progesterone, it actually goes just two metabolic steps over to allopregnenolone, which is desirable because that's the metabolite that actually does work at the GABA receptor. In the case of not enough progesterone, you have way too much androgenic activity, and that's usually what happens. These PCOS sufferers do not have enough progesterone, and partially because they're not ovulating. And then back to what's the underlying cause of all of that? I'm beginning to think that insulin resistance is just the platform for just almost everything here with hormone disarray. What's your opinion?
Absolutely. I totally agree with that. So I was going to say, I was always told in training and early in my career that every reproductive endocrinology fellow, their goal was to explain polycystic ovary syndrome, the basis and how it happens, because it was thought genetic. But recently it appears that insulin resistance is probably the basis, and that cascade of hormone changes that you talk about, they're progesterone deficient because so many of them do not ovulate, sometimes ever. So
Yeah.
you have to progesteronize them, or
Yes.
you have a higher risk of endometrial cancer, and that can happen in women in their 30s with undiagnosed or untreated polycystic ovary syndrome. And then
Uh,
we all know that they have a tendency to be type 2 diabetics. And what leads to type 2 diabetes? Insulin resistance and high fasting insulin levels that are chronic.
right,
So I
right.
think it's all tethered together.
I agree. Now, I had brought up, and I don't think we finished the discussion, Dr. Macari, who is
Yeah.
now our new FDA commissioner, wrote a book called Blind Spots. And in one chapter, he covers a surgery for ovarian cancer, and he maintains that the cancer is not in the ovary. It is in the fallopian tubes. And one of the things you could do for ovarian cancer is only remove the fallopian tubes, which is where the cancer is.
Yeah, we talked about that. I've never heard that. It's an interesting proposal because, like I said yesterday, the cancer of the ovaries typically the lining, the surface lining of the epithelium of the ovary. It's not technically in the ovary, it's on the ovary. And then, of course, when it spreads, it goes intraperitoneal. So people
Mhm.
that are, women with stage 3 ovarian cancer have metabolic hits all through their omentum and all through their abdominal cavity. But I mean, the fallopian tubes are not lined by the same epithelium. So
Yes.
it's an most ovarian cancers are cystadenocarcinomas, so they're gland based, so technically hormonal.
Mhm.
And fallopian tubes have a different epithelial lining on the inside, but a similar one on the outside.
Oh, maybe it might be the outside portion. Who
Might be.
knows? Yeah.
It kind of goes along with maybe I'm smarter than I thought without knowing I was smarter than I thought.
Uh-huh.
Because when women I did not like tying tubes. I don't like tubal ligation
Okay, so
because
expand on that.
okay, so I don't like it because it changes the ovarian blood flow. So 1/3 of the blood flow of the ovary is in an artery that's just under the fallopian tube. So if you clamp off
Have
the
the
tube, burn it, put a Hulka clip on it, put a ring on it, whatever you're going to do, you have created ovarian dysfunction immediately. And when I started proposing, let's not do that, there was no study that showed there was a change in hormone production until somebody finally did it, and it wasn't me. and showed a drastic reduction in ovarian hormone production after a tubal ligation.
I
But the reason I say I'm maybe smarter than I thought,
no.
if I did a tubal ligation, I removed the entire fallopian tube.
Huh.
So I told women, I said, look, here's the informed consent. If you are requesting sterilization, I am going to make sure that it is not reversible and it's permanent forever. So don't let me do it unless you know in your mind that you're done. So there are so many doctors that'll say, well, I'll do your tubal and I'll do it in such a way that down the road you can reverse it if you want to. And I'm like, well, if you're going to do that, they shouldn't be having their tubes tied.
Yeah, I did meet a doctor over the phone as I met you over the years,
Yeah.
in the beginning. And his whole practice was reversing tubal ligations and vasectomies. But he said to me, it's an incredible amount of symptomatology and level of state that's the symptoms disappear and health is restored after his surgery to change it around. So that was all he did.
That's it. Was he in Tennessee?
I think so.
Yeah,
Did you know? I'm trying to
I
think of
know.
his name.
I don't know his name and I've never met him or talked to him, but I know that practice.
Yeah, he was in a car accident and died. So it's
Oh,
like kind of his practice cut short. So
I didn't know that.
yeah.
And I always felt like if you were going to do a tubal reversal or a vasectomy reversal, you had to do it within a couple of years. And he would do it if it had been 10, 15 years, he would do it.
Yeah, yeah. I know, a very interesting situation. So let's move on to endometriosis.
Okay.
So we do surgery for that. And how is it done? What does endometriosis look like to a surgeon? And how do you get success? Is this successful surgeries or do you run into problems with that kind of situation?
Oh, sure. And if a woman came in to me when I was doing full-time infertility and said, I've tried to have a baby for a year to a year and a half, and it's not happening. And I did what was called a basic infertility evaluation and checked sperm counts in their partner. If I said you, and I didn't really find anything, I'd say you have endometriosis, and I would be right half the time. Even a woman just comes in, I can't get pregnant. You have endometriosis.
Yosis.
How do you know that? Well,
Oh.
I don't know that, but I'm prove it. But half the time, I'm going to be right.
Hmm.
So kind of like you were supposed to take appendixes out and be wrong 50% of the time
Yep.
back in the day. So endometriosis is not a death sentence for fertility, but it is only cured by menopause. So it is estrogenic. Estrogen is food for endometriosis, just like fibroids. So if you're going to improve, and of course, you're not going to take a uterus out on a woman who's infertile, permanently make her infertile. So I spent a lot of time dealing with endometriosis to preserve fertility. So hysterectomy was my last resort. If nothing else worked, I would say, okay, you're 40 years old, you're 12 years from menopause, you're in agony, it's horrible. I've done everything I can, including resect the endometriosis and do conservative surgery, and I have failed. Do you want to fix this and take your uterus out? It works. It works every time.
So those endometrial plaques, not only did I read somewhere that it can be actually almost microscopic
Yes.
in size, so even a surgeon couldn't see it. I've also read someplace that those plaques not only can be in the peritoneal cavity, even some have gotten to the brain. Have
So,
you?
yeah, I've taken care of a patient that had endometrial implants in her cesarean scar.
Wow.
That's since.
Yeah.
Uh, there's been reports of nasal endometriosis,
Oh my gosh.
where a woman would have a nosebleed during her period. She'd have a period below and she'd have a period in her nose.
Oh my gosh.
Lungs, brains. I mean, it can go anywhere. So endometriosis is like cancer, but it doesn't kill you. It makes your life miserable if it's painful. And of course, half the time, the number one symptom of endometriosis is infertility. It's not pain. It's not painful
Hmm.
intercourse, heavy bleeding. That's a subset. So the idea is to get a woman into menopausal state if you're trying to be conservative. In other words, a woman does not want to have a hysterectomy. And if you're doing a hysterectomy and it's an estrogenic phenomenon, then you should take the ovaries out as well,
Mhm.
which creates a whole nother issue.
Yeah, which we already talked about.
Yeah,
So,
what you can see is only part of it.
yeah.
And
So,
that came up like 20, 30 years ago, where guys, some of the AAGL people, the surgeons that were gynecologic laparoscopists,
uh-huh.
they would take out what they could see, and then they would biopsy around where they took it out, and they would still find microscopic endometriosis. So if you're going to do conservative surgery, you have to do kind of wide resection.
Oh, wow. So William Crook many years ago wrote a book called The Yeast Connection in the Woman, and he strongly felt that this was connected to Candida.
Endometriosis?
Yeah, had you
Yeah,
ever heard that?
I've never
Mm.
heard that ever.
Really? Really? So I consider that a possibility. I have checked out with clients with if they talk about that, I say I want you to take a Candida questionnaire and let's see if that's also a problem. But progesterone can be very helpful for endometriosis, but
Yeah.
you would need higher doses. And maybe what you would even like to have higher doses for a while that would suppress ovulation. What do you think?
Yeah, if you can suppress ovulation without the progestin component of a birth control pill, it would take a higher dose of progesterone. And like we said yesterday, most physicians and prescribers are like, oh, the top dose of progesterone is 200 milligrams. I'm like, no, it's
It's
not.
not.
That's from back in the 70s. That's how far out of date you are.
Yeah, actually, it's even further. Katarina Dalton and her PMS treatments and her identification of PMS as a syndrome. She found that the dosages that she ended up with were in vaginal suppositories, 400, 600 milligrams per suppository, and you might need that multiple times per day. She also found some interesting things like women who had severe PMS symptoms had normal luteal levels of progesterone sometimes. And then
Okay.
she also tested the peritoneal cavity for progesterone. She stuck a needle in there and pulled out some fluid and had it analyzed for progesterone. It was 1,000 times the luteal level when she measured it. So progesterone really compartmentalizes all over the body, and we have limited testing like saliva, urine, serum, but it doesn't give us the whole picture of what's happening in all these other parts of the body. I wanted to jump over to endometrial cancer.
Okay.
Okay, so some time ago, I think it was research done at the University of Southern California, and they had instances of endometrial cancer and they monitored progesterone receptors and found a decline as the disease increased, the receptor number would decline for progesterone receptors. So the conclusion for their paper, they were developing testing for progesterone receptors to monitor how severe your endometrial cancer was. In the foreword, they even went so far as to say that 50% of women had been treated in the past successfully with progesterone. But now I think, and maybe you can elucidate this, if you go to a physician now and you have a diagnosis, maybe by a sample, that you're going to be shunted right over to hysterectomy. Would you say that's the case now, or
That's true. Yeah.
that's true?
That's exactly true.
That's
And even you're going to be shunted to hysterectomy even if your pathology shows endometrial hyperplasia with atypia or atypical cells.
okay. What
It's
does
like
that mean? Atypia.
atypia is not typical, so endometrial cells that look funny is the best that.
Just
Under the microscope, you're like, oh, that's normal. Oh,
no.
that's weird looking. That would be
Uh-huh.
atypia. And so that is like an automatic knee jerk. Let's get your uterus out before you die.
Yeah.
And then you got to remember, there's a lot of people that hang their hat on the endometrial biopsy in the office, which is kind of dumb. And then you'll have doctors that'll say, well, the biopsy's negative, let's go to the OR and do a D&C, but they're not looking. So it is a red flag. So women that are menopausal, if they have vaginal bleeding, that's a cancer red flag. And the red flag is endometrial cancer or endometrial hyperplasia or polyps or whatever.
Mm-hmm.
But the only way you're going to know for sure that a person does not have developing cancer is to use a hysteroscope and look, and then curettage the entire lining of the uterus so that there's nothing left in there. So you curette, you look, you curette, you look. What I found the most, and I did this all the time, and I had it set up in the office. I could do hysteroscopic procedures in the office. I had a CRNA that would come in and twilight sleep patients. The most common thing I found for postmenopausal bleeding was endometrial polyps. And you would miss that on a D&C. You look with a hysteroscope, oh, there's a polyp, you grab it, pull it out, case
Done. Case
done.
closed.
And
Yeah.
there's plenty of, I'm going to guess there's plenty of surgeons that if you're 56 years old and you come in and you've had a period, maybe they'll look at your hormones if you're taking them, maybe they won't, but they're going to be pushing you toward, let's get that uterus out before you get uterine cancer, endometrial cancer. And then the other thing that we've seen, I reported on this a year ago, endometrial cancer rates, which is almost 100% cure rate with hysterectomy. The endometrial cancer rates have been rising for 15 years.
Oh my goodness.
Like significantly. And Wall Street Journal reported on it. So I jumped on that and I thought, okay, let's delve into the statistics. And it's true. Endometrial cancer is rising faster than I think any of the other gynecologic cancers that we deal with.
So if you had and suspected abnormal cells and atypica, right now a physician would not take the time to maybe treat you with progesterone and see if that would change.
No.
I did have the occasion to see this with progesterone given in Quicksilver Scientific as a serum with progesterone, which is pretty well absorbed. And we gave it to Frank Schallenberger for a young woman who had been diagnosed with stage 4 endometrial cancer. And
okay.
what would stage 4 mean? It's already
It's everywhere.
everywhere. Anyway, she would.
Metastatic throughout the body.
So,
Everywhere.
so she was diagnosed with stage 4 endometrial cancer. And I don't know what he did. He does a lot of ozone therapies, nutritional therapies. Plus, we had this progesterone. And in the matter of some weeks, I would say 4 to 6 weeks, her diagnosis was downregulated to hyperplasia.
Interesting. With
Yeah,
progesterone.
yeah. And whatever else he did. She was very young and she wanted to have children. So there's no way she wanted to give up her uterus.
I'll bet that was so that's one of those situations where you have a case like this guy does this, and if she would have progressed and died, that would have been considered malpractice.
Yeah, yeah, where you
Even
could.
though he was I'm sure he had very long conversations with this young woman.
But women don't even understand there's any other options. That's what I really liked on one of your TikToks. You emphasize that there's often many choices, and unfortunately, your doctor's presenting one thing, and we were focused in on hysterectomy, that's the solution to everything. When you do have multiple choices, here I'm talking about therapy with progesterone, maybe even for endometriosis, instead of just lopping off the hysterectomy.
Right.
Uterus and a hysterectomy. So it's rather shocking that this occurs. What about cervical dysplasia, the pap smears and
Oh, so I've got a long I'll try to keep my story short because I'm old enough and I did this long enough. I got story after story after story, and my students are like, oh, here he goes again telling some story.
Okay, before you
This
start your story, I'll just say a break here. Yeah, we
okay,
don't need to stop because I'll have the IT guy break. So I
okay.
just want to start again with introducing you.
Dysplasia. Okay.
Okay. Okay. All right. So hello again. It's Carol Petersen, and I am visiting with Dr. Bryan Treacy, who is a retired OBGYN physician. And one of the things we seldom discuss is why there are so many hysterectomies and what are the things leading up to it and what your choices can be instead of hysterectomy, where there are choices. If you have more information, you can find out about it. So, our purpose today is to talk about some of these situations and how women do have choices. There's things they can do for prevention or even treatment, that not all roads lead to hysterectomy. So, Dr. Bryan, we were just about to start a discussion on cervical dysplasia, cervical cancer, and you wanted to tell a case story.
Oh, I got a million case stories.
Okay.
So there are many, many women that will tell me, even when I was practicing, you had a hysterectomy, abdominal hysterectomy, and ovary removal. Why did that happen? Oh, I had an abnormal pap smear. And I go, well, cervical dysplasia and cervical cancer is now recognized as a human papillomavirus infection, which is transmitted by touch. So how is it that your doctor said, well, let's take your uterus out for something that has probably is an infection in your lower genital tract that is still there. So you've heard, I'm sure, that women they're told, and I just heard a woman yesterday, or no, this week. I'd say, when's the last time you had a pap smear? Oh, I had a hysterectomy 20 years ago. Oh, I don't need a pap smear. And I said, have you ever had an abnormal pap smear before your hysterectomy? And she said, well, yeah. And I said, well, that's a viral infection. There is no cure for a virus. The virus is human papillomavirus. It can also cause cervical cancer in women who don't have a cervix. She'd never heard that. So my position was always, I don't care if you've had a hysterectomy or not, you need a pap smear, maybe not every year. And I found cervical dysplasia on the vaginal cuff at least 10 times a year.
Yes.
Sometimes and several times it was moderate to severe dysplasia. So I would have to take them to the OR and laser their vaginal epithelium off
Hmm.
to take care. Now, did I have a patient go to cervical cancer after a hysterectomy? Never.
Hmm.
I did have patients that had cervical dysplasia and they didn't have a cervix.
Yes.
I've always thought, well, if you have a cervix, you have something you can work on.
Hmm.
If you get cervical dysplasia, you can work on that. You can cone it, you can leap it, you can freeze it, you can put trichloroacetic acid on it. Dr. John Lee talked about using progesterone for cervical dysplasia way back, what, 30, 40 years ago?
Hmm.
I'm not sure.
Doctor,
I'm not sure I buy into that because that didn't make sense to me, but it's
uh-huh.
there. It's out there.
Jonathan Wright, Dr. Jonathan Wright used to do injections with vitamin A around the cervix.
Interesting.
Did you ever heard of that?
I have never heard of that.
So
No,
I,
the most out there thing I ever heard was what your doctor might not tell you, may not tell you about perimenopause and menopause. That advocate for let's try progesterone before we start getting the knives and all the clamps out. So hysterectomy for abnormal pap smear prior to development of cervical cancer never made sense to me. Now, if you had developed cervical cancer, you have to have another conversation. But that is, the pap smear, George Papanicolaou, the pap smear is the single medical intervention that has saved more lives in the history of medicine, in the history of the world. So everybody doesn't like having a pap smear, but it has made a significant impact on preventing cervical cancer because it's all preventable. If you catch it early enough, you can prevent cervical cancer. It's the leading cause of cancer death worldwide for women under 40, cervical cancer, where they don't do screening pap smears.
mhm.
So I'm a big pap smear advocate, and the American College of OBGYN has completely changed their recommendations and they don't make sense to me. So you don't need a pap smear till you're 21. And my position is the first time you have sex, you need a pap smear. I don't care if you're 12, I don't care if you're 40, because I think cervical dysplasia and cervical cancer is sexually transmitted. And 90% of adults have human papillomavirus. There are 100 subtypes. The only way you would avoid HPV inoculation would be to never touch another human being your entire life.
Like,
And so there's
I-
100 subtypes ish. There's 15 of them that have the risk of turning into cervical cancer. Type 16 and 18 is supposedly covered by the HPV vaccine, Gardasil. That's a whole nother, Gardasil is a whole nother conversation. But
Yeah.
so I've always thought, look, if you're a female and you touch people, you need a pap smear.
It's okay. Okay. So, and as you said, there are many other things you can turn to first for sure
Yeah.
before a hysterectomy, and then throwing in the ovaries too, as they're wont to do. We covered a lot of bases. Did I leave anything out?
No, I mean, you said the ovaries. Think about taking somebody's ovaries out because they have an abnormal pap smear. That makes absolutely no
Absolutely
sense
innocent.
whatsoever. That's maybe the dumbest thing ever.
Yeah, truly is. Is it coded for more money when
Well,
that happens? If you
if
do
you,
a
yes,
uterus only is some amount of money and you chuck in
you,
the ovaries too, you get a little bit more.
you do, yes. What women
Ah,
don't, what the general public doesn't understand is, and I don't know the numbers recently because I haven't looked and I haven't operated for a while, but we started this whole thing talking about 600,000 hysterectomies a year.
right.
That has not changed in the 40 years I've been in healthcare. That
Huh.
same number has been propagated my entire career, starting in 1982 when I went to medical school. 600,000 hysterectomies in the US each year. The vast majority of them were done abdominally. And the reason is once they brought in the CPT code and the ICD-10 codes, insurance paid a higher reimbursement for an abdominal hysterectomy than any other kind. And I'll bet you that's still true.
Ah,
So it used to be that, 80%, it's changed since robotics and laparoscopy. I was a vaginal hysterectomy guru. That's what I did. I mean, I'd say my abdominal hysterectomy rate was probably 2%. The vast majority of them were done vaginally. And I'm talking about even for women that I was trained, well, you can't do a vaginal hysterectomy on those women because they've never had a baby vaginally, or they've had a C-section, or the uterus is too big, there's too many fibroids in it. And I always started vaginally, and I would convert to an abdominal procedure if I needed to. And I would tell a patient, you might wake up with an incision, but I'll do my best to do this so that a week or two from now, you're back to kind of doing whatever you want. So my conversion rate was never, if I started a vaginal hysterectomy, I never had to convert. And the 2% that I would do abdominally, I knew ahead of time there was no way I was going to be able to get this done vaginally
hmm.
based on history or ultrasound or whatever, or size.
Okay, I just remembered another thing. I worked with a young woman once, and she had four children, four boys, in
Uh,
pretty rapid succession. And then she had some uterine prolapse.
yeah.
So the off went the uterus.
Off went the uterus, yeah. And they probably didn't fix the rest of the fascial hernias, all the connective tissue that holds things together. So that's where
Oh.
the vaginal prolapse, the cystocele, rectocele come in. Okay, so here's story number 80.
Just,
I was in Tulsa, and there was a guy, a cardiologist, who developed home telemetry for his patients. So they didn't have to be in the hospital. So he set up this home telemetry thing, and he sold it for the rights to it for, or the patent, whatever, for $10 million. And he was in his late 50s, maybe. And he was sitting with his mother having coffee. And her mother said, well, doctor, son, you're such a smart guy. Why don't you come up with a way that women can treat stress incontinence, that, urinate without,
yeah.
can you figure out a way that you can treat stress incontinence for women so they don't have to have surgery? So he did. And he did it for his mother.
Uh-huh.
And I happened to see him in Tulsa talking when this product came out. It was a TENS unit for the vagina,
Uh-huh.
and it was called the Apex device. And that worked. It took care of pelvic floor dysfunction. It got rid of incontinence in 2 months. It got rid of cystoceles, rectoceles, prolapse, the whole 9 yards. So, and now you can't find them. I think he was
They,
so successful at it that they squashed it.
Oh no. What
Because
was it
one,
called? It was called the Apex.
it was called the Apex device. It was a $400 FDA approved device for dysfunction. And then he had a real fancy one, and I can't think of the name of that one. The top of the line was $800, and you could hook it into your laptop and measure what occurred at home with this device. So it looked like a sexual device.
Uh-huh.
So it went in the vagina, and it had a little blow up thing where it
Uh-huh.
would seat, and it would just rhythmically, passively do what physical therapists do with pelvic floor dysfunction. And it works so well. And of course, I couldn't test it on myself. I could put it in my hand and it would do
Uh-huh.
it passively. And so I met that, and I went up and talked to him after the thing. I said, I'm a pelvic floor. And I said, this device is going to put me out of business. And he goes, that's correct.
Perfect.
He said, and I did it for my mom.
So
So
there.
my guess is, so sure enough, I could not get women to do it. I'd say, this is a $400 device. You do it. All this stuff you're telling, prolapse, I'm peeing my pants, all that'll go away in 2-3 months maybe, and you own it forever. And they
Mhm.
wouldn't do it. They would pick surgery because insurance didn't cover it. And I said, but your deductible for surgery is $1,500, and this is
And
a
they,
$400 device, and they would always pick.
oh my gosh. We've really
So
been brainwashed somehow.
yeah, the
Just,
last time I tried to find one was for a woman that was in Illinois, that she's like, they want to operate on me and do this cystocele repair. And I go, that's not going to work. It was described in 1881. It doesn't work. Somebody's doing it today somewhere in the country. It always fails because it's not anatomically correct. So I tried to find one of these devices and I could not find it. So the only one that's still available is called Intensity, and it is sold as a sex toy, but it has the same TENS unit effect.
very interesting. Well,
And
that's a great clinical pearl here.
they're like $199 last time I looked. The company was called Inlet Medical, and this company, that is no longer, I think. You can find their website, but you can't get anything. So the device is called Intensity. It's sold over the counter as a sexual gratification masturbation thing, but it has the same technology and it will fix urinary incontinence and prolapse.
Oh, excellent pearl here.
Yeah.
So, as I just mentioned before, did we miss anything that
For hysterectomies,
for hysterectomy? We covered a
we,
lot of ground here.
we mentioned yesterday the PMDD thing. That's another thing that makes absolutely no sense whatsoever to me.
Thank you. Yeah, let's go into PMDD. And there's some history to this.
Oh yeah.
And it's in the late 90s when the drug Prozac was running out of its patent. And they were searching around for another thing to apply to the FDA for another drug approval.
Right.
And they produced a study that showed that Prozac, the first one, but then other SSRIs followed, that 50% of women had some relief when they used an SSRI. And in fact, they brought out this, like, I can't remember the name, but they got a little bit lower dose, and you're supposed to use it all the time, or you could vary the dose. I think you could use that during your cycle and be off for 2 weeks, which is contradictory to how they say you have to use Prozac and you have to use it for a few months before it's effective. So it's really a bunch of garbage, and I was so horrified because at the time I was working with a compounding pharmacy and treating severe PMS left, right, and center with very generous progesterone, so I know that works. But they have taught these women that they have to avoid progesterone at all costs. They are progesterone sensitive. And this is kind of the progression. They start with SSRIs. Of course, that doesn't work. And then they're going to go to maybe birth control pills in there sometimes. Then they go to gonadotropin releasing hormone blockers. So they shut off your whole endocrine system from your pituitary, and then they'll give you back estrogen. Actually, the very thing that's causing you some problems because the estrogen is not being balanced by progesterone that they're telling you you can't use. And in fact, if you did try to use it, they would say they would give you a little dose and you would have an absolutely miserable experience from that. So that reinforced your fear of progesterone. And then when all that failed, they would say, oh, you have to have a total hysterectomy because you can't handle the hormones that your ovaries are doing. And so I became acquainted with a woman in Great Britain. She's got a Facebook page only for those women who have been diagnosed with PMDD and now they have lost all their organs. And now again, just as they're saying, no progesterone, you don't have a uterus, and they're giving estrogen only, and they are in misery.
Yes. Yeah, that entire story is accurate and full of fallacies.
Yep.
That is all false, every bit of it.
Every bit of it is false, and it was all designed to sell Prozac and SSRIs, and now this.
Yeah, the new patent was called Seraphim.
Thanks.
Seraphim is now off patent, and fluoxetine, generic Prozac, is cheap. So then they come up with the SNRIs.
Nice.
And they're going to go off patent. So they're going to have to start messing with your brain chemistry a different way. And 2 years ago, they showed that serotonin had nothing to do with depression.
No.
But we're still writing Prozac like it's a tic tac.
Yep. And one of my biggest problems is when somebody comes to me on these drugs, it's really hard to remove them. And of course,
It is.
they're causing major imbalances in your endocrine system. I'll throw birth control pills in there too, causing some really major problems. Here's another thing. Here's another conspiracy just happening. There's a movement afoot to encourage birth control pill use for menopause.
Okay. That does, well, that makes sense, but it doesn't make sense.
Right, right. It's
When you have very, have very well-known protocols for menopausal hormone replacement therapy that go back decades and decades and decades
right. And
prior to the advent of oral contraceptives.
so yeah, it's not nice to fool Mother Nature, as one doctor I spoke to before, going into these synthetic hormones, which are really quite a lot stronger, and sometimes they produce the opposite effect of what the real hormone would do. So there are quite a lot of hysterectomies happening just because of that diagnosis and has nothing to do with.
One of my friends was a neurologist in Springfield, Missouri, and I don't know if she's still down there, but her practice was called the Headache Center.
Uh-huh.
And we would go out to lunch and chat about hormones. And she goes, absolutely, progesterone. There is a progesterone headache that is the basis of PMS.
Yep.
I'm not even going to qualify PMDD by calling it that because there is no such thing.
Yeah, yeah, they made it up. Actually, they first they got a drug approval for it, and
Right.
then later they put it in the DSM
Yes.
after they got the drug approval. That's
That's right.
how all contrived this all is.
Totally made up diagnosis. It makes absolutely no sense. So I asked her, I said, you use progesterone for luteal phase headache? And she goes, yes, I use high dose progesterone for the 7 days prior to the onset of menstrual flow. They can figure that out because most of the PMS symptoms or the progesterone inadequate luteal phase symptoms are that 7 days.
Yeah, the week before bleeding. But I want to throw in one other thing. I mentioned it a little bit earlier. Days 1, 2, 3 of bleeding. Some women have the worst headaches, the worst cramping in those days, and it's still okay to use high dose progesterone into those days and then either quit or drop it down to a much lower dose for the follicular.
Yeah.
And I learned this from the PMSers. They're regular as clockwork. It did not require progesterone to go down to bleed.
Yeah.
So there's other mechanisms going on here that we don't even know yet. All these millions of years.
That's why yesterday when I said progesterone withdrawal causes menstrual bleeding, that's why you said I beg to differ.
Yes, that's why I've got plenty of experience with that. And it's everybody's taught what you just said, progesterone withdrawal, 100%.
That is
And
exactly what I was taught, and that's what I still teach in my physiology class. I'm gonna have to rethink that.
yeah, you have to rethink that. All you need to do is have some woman with the worst headache of her menstrual cycle just when she starts bleeding, and you give her progesterone, you have to rethink your whole thing.
Exactly, yeah. So that begs the question, what is the trigger for menstruation?
Well, I thought maybe from my calculus study that the answer might be there, like area under the curve, that
Yeah,
you have to have enough progesterone collectively for some days that as it has its secretory function, which it doesn't start till 1 week before bleeding about. Before that, it's working along with estrogen to build a nice cushion. Midpoint is where it becomes a secretory hormone if no egg is implanted.
right.
So then if you are going along, let's say you're getting to be perimenopausal, and now you're not the bleeder person, you don't have that much estrogen stimulating, but you're starting to have scantier periods.
Right.
And you might have periods actually that you might miss some, no progesterone. You might have a small amount of progesterone. Like progesterone in the luteal phase in the serum, really a nice, robust, young progesterone level would be 20 to 30 nanograms per deciliter. And I see tests come back with serum progesterone on days 18 to 21, and their serum level of progesterone is 4.
Yeah.
So,
So that's part of my infertility workup, my what I alluded to, the BIE, I call it basic infertility evaluation. And a woman's trying to get pregnant, she will not get pregnant until her serum progesterone is 25 or higher, and probably and higher the better. So I would, I remember taking care of a woman in Omaha. She'd had 8 miscarriages.
mhm.
She was progesterone insufficient during her luteal phase, and all I did, and she had 2 babies after 8 miscarriages. All I did was give her progesterone after she ovulated and kept her on it until the 13th week.
Okay. I had somebody just randomly send me an email, and she had worked with a fertility clinic, and this clinic did a study, and she was apparently in it. They used extra progesterone throughout the whole pregnancy and
Yeah,
documented much better pregnancies and healthier kids, less nausea, less diabetes, the whole works. So I think there's the sweet spot somewhere with progesterone and a normal pregnancy. And we just don't, we take like a low level, I think like 50 nanograms per deciliter. That's pregnant.
yeah,
But would you have a better pregnancy if you were at 100 or and third trimester 200? And the other interesting thing from this test was they remarked that the serum level of progesterone in the fetus was 6 times that of the mom.
interesting.
Yeah. So whoa, I always say there's no way we can overdose progesterone, and I don't believe so. Fetus progesterone is a sexually neutral hormone, even though we can connect it to pregnancy all the time. But that fetus concentrates all that progesterone and very small, small body weight, obviously.
Then how did they do cord blood sampling, or how did that get
I
done?
don't know how they did it. They just produced that as a statement.
Well, my little rule was if you got to your 13th week, I would keep testing your progesterone level.
Hmm.
The placenta was supposed to take
Yes.
over, and if it was
Mm.
too low, I would give them shots, or I would
Yeah.
keep them
Yeah.
I would keep them on progesterone. And then that Society of Perinatal Obstetricians came out with progesterone reducing risk of premature birth for women that had a preterm delivery.
Yeah.
So progesterone has not really been studied that much in pregnancy at all.
I know. Isn't it amazing?
Yeah, and
Oh,
it's required. I mean, it is required to have a successful pregnancy in the first 13 weeks. It's
yeah.
required.
Right. Right. I
So
had I had the pharmacy board come and visit me. Somebody got a prescription for 25 milligrams of progesterone, I
uh,
think in a suppository, and she was told to use it after she knew she was pregnant.
That
And
was routine. That was routine when I was in Omaha
but how
before
are you supposed
transition.
to get pregnant in the first place? You're not going to get pregnant if you don't have that higher amount of progesterone, like the mid-luteal
Yeah,
progesterone. You have to keep that up. And we'd been working with fertility clinics. Of course, they were doing 100 milligrams 4 times a day. So I told her to go back to her doctor because she could be using it earlier for better success, and she should be using much more. And that doctor complained to the pharmacy board, and they came to visit me. Toot sweet.
yeah, toot sweet, toot sweet. You are in Canada now. You can say toot sweet all day long.
Yeah, I could say toot
Uh,
sweet all the.
yeah, mine was 50 milligrams of progesterone 48 hours after documented ovulation. And then once pregnancy had occurred, they continued that for 13 weeks. So
Hmm.
that's less than you were talking about. It was 50
Hmm.
milligrams IM. So I'm trying to remember how
50
much.
milligrams IM is very effective. You have 100% absorption.
Yeah,
So any of the other dosage forms will not give you that, no matter what.
right. So I don't know how that would translate to 25 milligrams in a suppository.
No way.
That's like hardly any.
It was hardly any. I was just appalled.
And
And
so the pharmacy board dropped that or what?
oh, they dropped it.
Yeah,
I just said I said I did just do what I was supposed to do. I said if there's a question about a prescription, I asked the patient to go back to the doctor. And
yeah,
I said we have a lot of evidence here with infertility doctors if you need some background. And this was her purpose. So I questioned the dosing.
yeah. Fair.
They left me alone then. So I was taken
Well, that
aback.
to the that stupid statement that we've heard the science is settled. I'm like, no, it's not. Science is never settled.
Never.
Ever, 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 ever. And if it's ever settled, that means the end of the world is happening and we're all not going to be here anymore.
Okay, so we went through a lot of information on hysterectomy. I want to also insert here, and you mentioned this in one of your podcasts or TikToks, the Hearst Foundation,
Yes.
and I think they do amazing work. And for anybody being told that hysterectomy is the choice you have, it's an excellent resource. And anybody who's told that a hysterectomy will solve all your problems and you'll never have any more problems, you really need to check in with these people at the Hearst Foundation. I think it's Nora Coffey
Yes.
was the founder. And we had one pharmacist used to say, if somebody's contemplating a hysterectomy, they should go take a shot of Lupron first.
Yes.
And he
Makes
said,
sense.
that's the gonadotropin releasing hormone blocker, blocks all your hormones.
It's actually interestingly enough, it's an agonist,
And
but
then,
it
okay.
down regulates, yeah, it down
Yeah.
regulates the hypothalamus.
Yeah, exactly.
So the negative feedback loop shuts the hypothalamus off, and then the hypothalamic pituitary ovarian axis is dead.
Right. So you can find out how dead you feel after all your hormones are cut off and reconsider your hysterectomy.
Right.
And at least it only blocks you 3 months, not your whole life.
Right.
So,
Well, the Hearst Foundation was the basis of why I did. I mean, you published a blog post and I ran with it. And I thought, well, I can do a series of hysterectomy videos, little short ones. And interesting, the comments on that, the women who were completely satisfied with their hysterectomy thought I was an idiot and a moron. And then other women would say, I wish I would have had this conversation with my surgeon before I had a hysterectomy because I
mhm.
was forced into it or significantly urged into it. And I had a couple women that say, "Oh, you're one of those dumb gynecologists who thinks hysterectomy is a bad idea." And I'm like, agreed. It's a stupid idea.
Idea.
So I think one of the videos had to do with meeting surgical criteria from ACOG.
American College of Obstetrics and Gynecology.
That's right. So something like, I can't remember the percentage, but I had it in the video. The vast majority of hysterectomies done in the country do not meet the criteria put out by ACOG for saying this meets the criteria for hysterectomy. So most of them do not meet that.
Oh my gosh.
So I would say that 98, I'm going to say, I'll go out on a limb, 98% of hysterectomies done in the United States are elective. That might be high, but
Yeah, that's
I
what
would bet
I'm.
at least 90%. In my hands, when I was practicing, I could talk them out of it more often than they would choose to do it. And I would say, here's your 6 options. Let's work together through all these and figure out what fits your personality and the rest of your life. And
Okay.
if you have that conversation, most of them will choose one of the
Something.
other options.
Yeah, something else. There's always something else.
Always.
So now that you've gone and had that hysterectomy,
Yeah.
how do you take care of that patient?
Well, then we do my so what I did was I got into menopausal medicine by treating what would be considered advanced maternal age infertility patients.
Just
So
goodness.
women from 37 to 35 to 45. So
Uh-huh.
the oldest patient that I delivered who came to me for infertility treatment was I can't I gotta stay private. She was a
Hmm.
professional woman that came to me at 45 and she said, I have this great career and I forgot to become a mother.
Hmm.
And I said, well, you're 45. And she goes, I'm game if you are. And
Uh-huh.
I said, okay. I said, it might take a while. She got pregnant. It took about a year. And she delivered the week she turned 47, and I delivered her.
Uh-huh.
So what I realized treating women in their 40s was that when you balance their hormones, which you have to do for infertility reasons, they felt younger and more alive and thought clearer and felt younger. I mean, they just felt like they did when they were in their 20s and
Hmm.
right around 30. So I got in my little brain, I thought, well, what would happen if I did this for women in their 40s and we didn't try to get them pregnant? That's how I started. So if somebody's had a hysterectomy and they're put on Premarin, which is typical, they would come to me and they go, I feel horrible. I take this Premarin, nothing's, this, that, and the other thing. And I go, you're progesterone deficient. Yeah, I didn't need Provera. And I said, well, you don't need Provera, you need progesterone.
Hmm.
So if their uterus comes out, if I did a hysterectomy and took the ovaries out, I would immediately start hormone replacement therapy. And I
Yeah.
would monitor it every 3 months and adjust accordingly. And I did that with the compounding pharmacy that you used to work for starting in 1991. So I was a young pup of 31 treating women with compounded hormones because I figured out I would not use Premarin, but I only had estrase, a milligram, 2 milligrams,
Hmm.
and a milligram wasn't enough, and two milligrams made their breasts change. They'd get
Uh-huh.
bigger breasts, so they'd
Yeah.
hurt.
Yep.
And I go, okay, so I had to take a 2 and cut it in half, and I called your former pharmacy for some reason. Somebody told me about that pharmacy, and I called a pharmacist and I said, here's my dilemma. A milligram of estradiol too little, 2 milligrams is too much. He goes, you tell me what you want and I'll make it. And I go,
Uh-huh.
do tell.
Yeah.
He goes, yeah.
The
So that's how I started. I'm like, okay, 1.25 still isn't enough. Let's try 1.3.
Mhm.
And I would find the dose and they would go, perfect. It's great.
Yeah, yeah. It's amazing, isn't it?
Yeah.
That's why I saw miracles all the time. And post-hysterectomy women can get their life back. They can get their quality of life as long as you pay attention to the myriad of hormones that are really off balance. And some get too much, like cortisol can be too much, adrenaline can be too much, you can have too much insulin. These things can be adjusted and you regain your quality of life.
Yeah, I've been kind of a fan of the urinary metabolomic hormone breakdowns, which most people know as the Dutch test,
Hmm.
ride urine, whatever that stands for. They're not cheap, but they give you the picture. You know exactly what's going on. So I found a lab called Physicians Lab that has the same exact test. And they have what's called urinary metabolomics, which tells you your gut health, your cortisol health, kind of gives you a picture of how you're doing at whatever age you're at. And then you can kind of pick and choose. Okay, that's a problem. Let's work on that. Hormones is one problem, but let's work on gut inflammation. Let's work on insulin resistance.
Right.
Let's work
Thyroid.
on muscle health, thyroid, vitamin B12 for red cell production,
Yeah. Vitamin D often, another hormone.
vitamin D. Yeah.
There's so much that can be helped. And we have so many tools. I always say for the first time in human history, we're able to top off our hormones and we're relieved of those symptoms of aging
Yeah.
that are really hormone decline.
Yeah. And then once you get the hormones right, then you start talking about the peptides.
Okay, that's another talk.
That's right.
Okay.
I'll send you, I did that urinary test on me.
Uh-huh.
It was very enlightening. So I'll send you my results because I put them up on TikTok. Okay, see, this is what this tells you.
Uh-huh.
Very handy, and hormones is only part of it.
Cool. I'd like to see it.
Yeah.
Okay, Dr. Bryan, thank you for taking the time to chat with us. This is such important information. It's tangential to the hormone picture, but it's really real life experience and what happens. And you have more alternatives that you haven't heard before. You have a foundation, the Hearst Foundation, which is full of information around this. We want to cut down that number of hysterectomies considerably. We don't need to have them. Any final words from you?
No, I mean, yeah, any woman out there that the doctor's saying your only option is a hysterectomy, you need another doctor and a second opinion, if not a third, because you'll find a doctor like me that says, okay, here are the other options that are just as viable without having major surgery.
Mm-hmm.
We're out there, we're just not numerous.
Okay, okay, okay. That's true. Well, thank you very much.
You're welcome.